And good evening, everyone, and welcome to the Oculus Clinical Webinar Series. My name is Dr. Bill Tulo, Chief Medical Officer at Oculus, and tonight I'm really excited to have the inventor of IPL for dry eye, Dr. Rolando Toyos, going to speak to us about intense pulse light strategies for clinical success. Dr. Rolando Toyos received his bachelor's and master's degrees from the University of California, Berkeley, and Stanford University. He then received a medical degree at the University of Illinois, where he was class president, graduating with the James Scholar Academic Honors. He completed his internship in internal medicine at Illinois Masonic Hospital in Chicago and completed his ophthalmology residency at Northwestern University and Chicago's Children's Hospital. Dr. Toyos is board certified in ophthalmology and specializes in cataract surgery, LASIK, glaucoma, and dry eye. He's one of the most experienced surgeons in the country, completing over 35,000 cataract surgeries, 20,000 glaucoma laser treatments, and 25,000 LASIK surgeries. Dr. Toyos is the inventor of the procedure Intense Pulse Light, IPL, for dry eye disease. He has trained hundreds of surgeons, both nationally and internationally, on surgical techniques, medications, and new technologies. He's also authored several papers and books. Without no further ado, Dr. Rolando Toyos, take it away.
So I want to thank Oculus for this opportunity to talk to you about strategies for intense pulse light for clinical success. Many times when I'm training doctors on IPL for dry eye and I tell them there's an aesthetics use for this technology, they go, oh, I just want to do the dry eye part. I really don't want to get into the aesthetics. But usually they call me about 3 months later and say, hey, can you tell me a little bit about the aesthetics? Because I got patients that are saying my skin looks so good. Can you do a full face treatment? Or they say, I have got a teenager with acne. Can you correct their acne with some IPL? Or you have staff going, you've got this IPL system. Why don't you give me a photofacial? So invariably, I wind up training doctors on the aesthetics part. And that's actually a good thing, because the two fastest growing markets are dry eye disease and aesthetics. Once you get IPL, it really is the best starter for getting into aesthetics, because it can do so many things like acne, photofacial, rosacea, and dark spots. And actually, this is how I discovered IPL in the first place. So when I opened up my practice, I did LASIK, general ophthalmology, and also had an aesthetics wing to the practice, where I bought all these different technologies for aesthetics, including IPL. So when I first introduced this idea, people were like, well, we don't see how eye care and aesthetics come together. But really, if you're working on people's eyes and around the eyes, most aesthetics clinics will not do anything around the eyes. They actually stay away from it. Once a patient has confidence in you to take care of their eyes and take care of their lids, they'll always ask you if there's other things that they can do to improve their skin, get a more youthful look, some facial rejuvenation. So this is a concept that people are going, I don't know if this is going to work, but it actually worked really, really well as a business model for Toyos Clinic. And we've continued to progress in combining eye care and aesthetics. So this is how I discovered IPL for dry eye. I had patients with rosacea, and IPL was a treatment for rosacea, and it's one of the early treatments for IPL. So applying IPL would close down those telangiectasias, improve the skin, decrease inflammatory mediators on the skin, and their skin would improve. But I had a group of patients that said that their dry eye improved, and that's what got me started studying the correlation between IPL and as a dry eye treatment. So the first paper was 2001, and I had this case report published by iWorld, and then Ascaris gave me a grant to look at IPL for dry eye disease. So what really it did for me is it changed my definition. Seeing that IPL worked for dry eye changed my definition of dry eye disease. So I see this as a skin gland problem. So if you have problems with your skin, you're going to have problems with your glands. Those glands are going to make abnormal secretions, giving you an abnormal inflammatory tear. This could be an isolated problem just around the face and the glands, or it could be a manifestation of a systemic disease. So a face problem would be like rosacea. Systemic disease would be something like lupus or rheumatoid factor that's affecting the skin of the face and the lids. And this abnormal tear breaks down the ocular surface, and if you don't do anything and you delay treatment, you're just going to get worsening of the glands and worsening of the tear foam. And this can cause chronic pain as it affects the nerves, and it can affect the activities of daily life. So you're going to need a multi-pronged plan to treat this disease. So if you look, skin diseases have a high incidence of dry eye disease. So 80% of rosacea patients have meibomian gland dysfunction and dry eye. Acne patients have a higher incidence of meibomian gland dysfunction and dry eye. Sun-damaged skin, so as the older we get more damage to our skin and our glands work less. One of the reasons why our basal tear secretion decreases as we age. So before I even look at a patient at the slit lamp, I look at their skin and see, and you can oftentimes, looking at their skin, tell if there's going to be meibomian gland dysfunction. So we're mainly going to be talking about evaporative dry eye disease when we're talking about intense pulse light. I did show in the early studies that we had an increase in Schirmer's. It turns out that the lacrimal gland is affected by these wavelengths of light and could help lacrimal gland function. It's one of the reasons why IPL is sometimes used on the thyroid to stimulate thyroid function. So now with the ability to treat in different areas with smaller tips on IPL, we can actually stimulate the lacrimal gland to work better. So what we're trying to do in our clinic is streamline the process of diagnosis. One of the ways you can streamline the process is with the keratograph 5M. You can have your technicians use the 5M to do a variety of tests, and you can create a baseline so that you have comparisons of after you're treating with IPL if these signs are improving, and you have something objective to look at. So the 5M provides a lot of different things that I utilize in the clinic to use as a baseline for patients and to follow patients. One, to see objectively how bad their dry eye disease is, and then what kind of improvement we get in their dry eye over time. So it's got tear film quantity and quality, meibomian gland assessment. You could see damage to the corneal surface. You can check for redness, which sometimes is the number one reason why patients are coming to the clinic, not knowing that they have dry eye disease, but complaining of redness of the eye. That's affecting their job, that's affecting their social life. So assessment of tear quantity, so looking at the tear meniscus. So instead of Schirmer's, even though we use Schirmer's for a lot of studies, I actually look at tear meniscus to see if they have a normal tear meniscus. This is a great way to tell if somebody has Sjogren's. If they don't have a normal tear meniscus, it's probably because they have some problem in their lacrimal gland. They're not making enough water. Now, sometimes a tear meniscus can be misleading, especially with a patient with severe meibomian gland dysfunction, and that's because if they have MGD and they're not making any fat in their tear, the body will make up for that lack of fat. They don't want the cornea to dry up. The lacrimal gland will produce more water. So sometimes the tear meniscus can be actually even greater in some of these patients with severe meibomian gland dysfunction because the body's trying to make more water so that the cornea doesn't dry out. We did a very interesting study using the tear meniscus height, looking at how quickly Tyrvaya, the nasal spray, could produce a tear, and we showed that within 5 minutes we get an increase in tear meniscus and production of a tear with a single spray of Tyrvaya in both nostrils. And then we can look at non-invasive tear breakup time. What I tell people, what I've learned with non-invasive tear breakup time, it's a little bit more sensitive than a fluorescein tear breakup time. So that I usually add about 2 seconds to what we see on a non-invasive tear breakup time. The reason being is these are so sensitive that they'll pick up the first spot and of dryness, whereas on a fluorescein what we're doing is we're seeing a spot and then that spot increases over the course of time, and then that's what we're saying is the tear breakup time. So if you see a non-invasive tear breakup time of 4 seconds, I usually add about 2 seconds, say it's about 6 seconds if I'm not going to do a fluorescein. You could look at the lipid layer, and you could look at the tear film dynamic using the 5M. Conjunctival redness. This is, again, very important part that patients often complain about, is how red their eyes are and how it's affecting their activities of daily life. So you have a conjunctival redness measuring component to the 5M, and it will grade it so that you can go from grade 0 all the way to grade 4. And this is great for those patients with red eyes, because essentially what happens is they get better. They don't realize the amount of improvement. So you have a picture there to show them of what is before and what they've gone down to. All right, IPL. So the Darwin Lucent system of IPL, very versatile. You can upgrade to different systems on it, but the system here in the US has IPL and RF. So I'm going to talk about how to use those and the science behind them, and how to best incorporate them into your practice. Mybography. The mybography is something that we will see in the 5M, kind of very important part. Actually, this is the one that I look at the most before I come in to see the patient, because what you can do is patients don't realize the extent of their disease or what their disease is. And with these pictures with mybography, we can actually show the patient the extent of their disease. So I tell them, you usually have about 20 meibomian glands in each lid margin. They're usually nice and straight and long. And as you can see in this picture, we see that the meibomian glands are shortened, abnormal. Some of the glands have dropped out. Some of the glands are shortened, segmented, twisting. So you could show the patient this and say, show them a normal and show them their picture and say, this is the problem. All right, back to IPL. So how does IPL work? IPL is not a laser, it's actually a xenon flash lamp. If you remember back to your chemistry days, looking at the periodic table, xenon is one of the stable gases. What we're doing is we're putting this stable gas in a tube, putting electricity through it. It becomes unstable, but quickly it regains its stability, and when it does, it releases a flash of light. That light is anywhere from 400 nanometers to 1,000 nanometers. What we do is we put a cutoff filter to block out those wavelengths of light that we don't want, to allow the wavelengths of light to reach that we want to reach the skin, and then we can pulse that energy so it's not given all at the same time. So what we've learned over the years is the most important wavelength of light when we're talking about meibomian gland dysfunction and dry eye is red. That's 600 to 700 nanometer. So that's why we're putting a filter like a 585 filter or a 600 filter to block out those lower wavelengths of light like blue so that we can get to the red. What does the red do for us? It actually goes past the epidermis, that wavelength of light, down to the dermis, hits the oxyhemoglobin in those telangiectasias and coagulates those blood vessels. Also, these wavelengths of light are absorbed by the pigment of the skin. So if you learn anything in this lecture, is that when you have darker skin types, these wavelengths of light are absorbed by the pigment in that skin and create a lot of heat. That's why you have to lower the energy levels in patients with higher Fitzpatrick skin types. So in a Fitzpatrick 1 with very little pigment to their skin, what you're going to do is you can increase the fluence, the energy that you're giving them. So say you can do 14 joules of energy, because the pigment is not going to absorb any of that energy and create heat in the dermis. But then you get a darker skin type, a type 4 or 5, you're going to have to lower the fluence, lower the energy down to 10, because the pigment is going to be absorbing that energy and generating a lot of heat in the dermis. So this gets us to a concept, and it's a very important concept when we're talking about IPL for dry eye. Is one of the things that we learned early on, and when you do IPL for dry eye, the closer you get to the lid margin, the increase in efficacy. So if you were to just treat down by the cheekbone, your efficacy of IPL for dry eye is going to be very low. We want to get these wavelengths of light closer to the lid margin. So how are we going to be able to do that? And this is where improving the technology has made it easier for us to do IPL for dry eye. When you get to the lid margin, which is the thinnest skin of the whole face, you don't want to give them all of the energy all at once. You actually want to use the pulsing ability so that you can give some energy and then allow thermal relaxation to happen. And what is thermal relaxation? You're generating heat in the dermis, and you want that heat to dissipate. So you're giving milliseconds of time between pulses for that heat to dissipate before you give them another burst of energy. So if you gave them that burst, all of that energy all at once, you could cause scarring in the lid margin. So how we got over that is by changing the energy levels for different skin types, and also by increasing thermal relaxation time between pulses to allow for dissipation of heat. Another mechanism of action of intense pulse light is actually decreasing the inflammatory mediators on the skin. But in these patients, we find that they have an increase in inflammatory mediators in their tear film. So not only are they producing less of a tear and an abnormal tear, but they're producing an inflamed tear. And interleukin-17 is the most specific inflammatory mediator for a dry eye patient. And what we've learned is the reason why T-cell immunomodulators work at drops is because T-cell immunomodulators control the amount of T cells that you're making, and T cells make T helper cells, and T helper cells make interleukin-17. So if you can control the amount of T cells that are produced by using a cyclosporin or a lifitegrast, you're actually going to decrease the specific inflammatory mediator that we see in dry eye. And we did a study showing that IPL not only decreases the inflammatory mediators like interleukin-17 on the skin, but it actually decreases the amount of inflammatory mediators like interleukin-17 in the tear film after a few treatments of IPL. Another mechanism of action is that IPL can kill microorganisms. That's why we're seeing IPL machines called the Xenex robot that is being used in hospitals and surgery centers, where you put in this Xenex robot, it flashes IPL throughout the room, and that kills microorganisms. So we find that IPL is great for decreasing bacterial blepharitis and also decreasing the amount of Demodex on the lids. As we know, Demodex dives into the hair follicle and the pores on the face, with the Demodex follicularum being the group that is around the hair follicles and around our eyelash margin, and then the Demodex brevis, which is found in our skin. Now, I think IPL works in two ways. One is if there's Demodex that are exposed to the wavelengths of light, it will kill them. And also, when we improve the tear film, there's lysozymes in the tear film that improve the blepharitis and kill this bacteria and Demodex. And in those patients that have a severe demodicosis where the IPL alone does not take care of the problem, that's where I use ivermectin plus, which is a patented formula of ivermectin with melatonin. But what is the main number one reason why intense pulse light works to improve meibomian gland dysfunction in dry eye? And that's photobiomodulation. That these wavelengths of light actually stimulate the mitochondria of the meibomian gland cells to work better. And when you improve the function of the cells, you get a better tear, and then our natural tear and the molecules in our natural tear can improve the ocular surface, and it just builds on itself. So this is a way of treating the root cause of the problem of meibomian gland dysfunction. And photobiomodulation is being used in all areas of healthcare. Photobiomodulation with wavelengths of light is used to treat age-related macular degeneration with infrared, red light, and some yellow light. In aesthetics, red light stimulates fibroblasts to make collagen and elastin. In orthopedics, they're using infrared to help patients heal tendons and muscles and ligaments, and we're using photobiomodulation to stimulate the meibomian glands to work better. And why do we need photobiomodulation? Because we have these patients with meibomian gland dropout. And what I've discovered is meibomian gland dropout isn't that these glands are scarred down and will not work. it turns out that once the glands fill up with this toothpaste-like secretion and they're not being used, the gland goes dormant. It's kind of like if you were to put a cast on an arm, don't use the muscles in that arm, what happens is the muscles will start to atrophy. I think that's what happens with these meibomian glands. As soon as you take the cast off and you start working out again and working those muscles again, the muscles come back. And that's the same with the meibomian glands. Once we get them these wavelengths of light, we stimulate the cells to come back and work again, so that you can get production from these meibomian glands. So if you're doing meibography on these patients that you do the 4-treatment protocol, it usually is about 3 to 6 months before you see changes in the meibography, but you will see production of meibum way before that. So usually if I'm doing meibography after we've done the baseline with the 5M, I'll usually wait about 3 to 6 months. So both myself and Dr. Rita independently both showed how we can bring meibomian glands back after IPL treatments. So if we're stating that photobiomodulation is the number one reason why IPL works to improve meibomian gland dysfunction, what we want to do is help our patients with the mitochondria. And the mitochondria need the coenzymes NAD and CoQ10. And what happens is these coenzymes, as we get older, decrease. And with certain medications, they decrease. So after the age of 40, our production of NAD and CoQ10 go down. So if we really want to stimulate these cells to improve with photobiomodulation, we do supplement. So with my patients, I supplement with NAD and CoQ10, especially if they're over the age of 40. It's also been shown that CoQ10 can help in help the nerves of the body. So CoQ10 is being used in glaucoma and in neurological problems. So if you have patients with loss and neurotrophic keratitis or problems with the nerves in their cornea, which we're seeing when we do confocal, that all these patients have some nerve problems, you can supplement with CoQ10 and NAD. And all the supplements that I recommend for our dry eye patients is in my latest book, The Toyos Dry Eye Diet, where I talk about lifestyle, diet, and everything in terms of treatment for dry eye disease. So it's a great book for patients and staff and doctors. I take no proceeds for any of my books. All the money goes to the foundation to help patients who don't have money to pay for treatments or health care. And then meibomian gland expression. So when we generate heat in the dermis, we're melting these abnormal secretions and causing dilation to the opening of the gland. So this is a great treatment to express the glands and see what exactly they're producing. Now there's some controversy, and it shouldn't be controversial, of should you express after every IPL. If you look at the FDA studies, and 90% of the studies, it's IPL with expression. So the problem with not expressing is that these melted secretions will over time just harden again and stay within the gland. When you're expressing the glands, you're actually, if they have any cells in that gland that can produce a normal meibum, now it's free to, because there's nothing blocking it. Also, when you express the glands, the next time the patient comes in, the gland is more open to absorb more light, so you're going to get improvement. I've tried IPL with expression and IPL without expression. The doctors that are doing IPL without expression, they're not having the same efficacy as patients that do get expression. We're getting a lot more patients that have gone and had IPL at other places without expression, and I can tell you that their glands don't look like they've had the full treatment, and they're not improving to the point that they need to be improving. So if you want to increase your efficacy with IPL, express after every treatment. And then what are we looking at with these patients? So this is a patient with meibomian gland dysfunction and dry eye, and this is what they look like before. They've got telangiectasias throughout the lid margin. They have a thickened lid margin because there's such a buildup of abnormal meibum. Their lid looks red, irritated, loss of eyelashes because you get an overrun of Demodex flooding into the hair follicle and displacing the eyelashes. You could see the telangiectasias not only on the lid margin but at that thin skin of the lid. This is one of the reasons why the eye doctor might be the first doctor to diagnose rosacea, because on our slit lamp we could see these abnormal telangiectasias that secrete inflammatory mediators. And then this is post-IPL. Same patient. You see that we've closed off a lot of those telangiectasias. The lid margin isn't red. Eyelashes have come back. There's not the thickening of the lid margin that we saw before. You don't see any signs of blepharitis like scurf, collarettes, pouting of the hair follicle. So this is one of the results that you're looking for post-IPL treatment. So the mechanism of action: killing of bacteria and Demodex, decreasing inflammatory mediators on the skin and the eye, expression, closing off abnormal telangiectasias, and photobiomodulation. One other thing, and this is when we start talking about RF, is when you generate heat in the dermis, and it's not enough heat to actually scar glands or scar skin, these heat shock proteins are produced, and these heat shock proteins actually will help the DNA of cells to work better. So heat shock proteins is another mechanism of action for IPL. So the Lucent IPL system has different heads that you can use. So it has a smaller head so that you can treat the upper lid. It has the ability to change thermal relaxation time, which helps you in treating patients with different Fitzpatrick skin types. It has the ability to change the pulse, the number of pulses that you give, again helping you with different skin types. And it also has a chiller, a cooling tip, so that you're not burning epidermis every time you're doing an IPL on the skin. And that's important because in the early days of IPL, when we were just giving a whole bunch of energy all at once, each time you were doing IPL, you were burning epidermis. So this is the reason why we would have to wait 4 weeks in between treatments because we had to let that epidermis heal. Now with a chiller, you're not burning off the epidermis. The epidermis is staying relatively intact, so that the patient can come in within a week or two to get their next treatment. I usually wait 2 weeks. That's ideal. If you have a patient that is on a shorter timetable, you can treat in 1 week, then the next time treat in 2 weeks, then 1 week, and then wait another 2 weeks for the final treatment. So you have different tips. So with the smaller tip, you can do upper lid treatment, and with the larger tip, you can do trachea to trachea. So I'll show you in a second here the protocol. So the pulses, so this is where thermal relaxation comes in. In between the pulses is you have the ability to change the amount of milliseconds all the way up to 100 milliseconds in between each pulse to allow thermal relaxation. So I use triple pulse for meibomian gland dysfunction and dry eye, and then I will change fluence and thermal relaxation for different skin types. So for higher skin types like type 4 and 5, what I'll do is I will increase thermal relaxation time to the max at 100 milliseconds. I usually leave the amount of milliseconds per pulse, and this is something I've studied over the 24 years of doing IPL. I'll usually leave it at 6 milliseconds of energy per pulse. And then I will play with the fluence, where darker skin types are getting less joules per treatment. So type 4 will get 10 joules, whereas type 1 will get anywhere from 12 to 14 joules. A big problem in the early days of IPL is energy stability, that across the board you would program 10 joules, and if you measured it, sometimes the pulse would be 10 joules, sometimes it would be 6 joules, and that the more you used your IPL system, the less energy you were getting per treatment, meaning that if a patient came in and you gave them 10 joules, and then they came in a month later and you programmed 10 joules after doing a bunch of treatments, the IPL machine would not produce 10 joules. It would produce something like 9 joules. So we were constantly changing the energy levels, increasing the number of joules we were giving patients because the output of the IPL system was lower. You don't have to worry about that with this IPL system. It's a newer generation IPL system where the energy level you program is the energy level that you get shot per shot, and that stays stable over 100,000 shots. The safety of doing the upper lid, we were the ones that did the study showing that we can get improvement in upper lid treatments just by doing the upper lid with a smaller tip. Now, why do you need a smaller tip with the upper lid? And the reason being is that with the orbital rim, there's less space for you to get the diffusion and thermal relaxation time. So the upper orbital rim was stopping that diffusion of heat. So the answer to that is making a smaller tip so that you, in between shots, you're leaving space for thermal relaxation to happen. What we discovered is the upper lid doesn't need much energy to respond. since it's even thinner skin than the thin skin of the lower lid, you don't need as much energy. So for upper lids, and it doesn't matter whether it's a Fitzpatrick type 1 or a Fitzpatrick type 5, I just use 10 joules for the upper lid. The other question is, there's doctors out there that are using internal corneal shields. You have to use an external corneal shield to block the wavelengths of light away from the hair follicles of the eyelashes, because IPL used to be used as a treatment for hair removal, because the pigment, the hair follicle will absorb the light and actually kill off that hair follicle. So you have to protect the eyelashes. So that's why we use external shields. Now, an internal shield, why do we not want to use an internal shield? What we're finding with internal shields is that they cause, looking at confocal, that an internal shield with IPL causes inflammation to the cornea. Also, we found that people that use internal shields can also cause damage to the epithelium. So we've had patients that have had IPL with internal shields that have had abrasion so bad it goes down into the Bowman's area, leaving the patient with EBMD after their treatment. Why do you not have to use an internal shield? Because these wavelengths of light will not do any type of damage to the eye. These wavelengths of light can't penetrate past the dermis. There are studies or reports of patients that get IPL directly on the eye, that's without their lid closed, where they get damage to the iris, causing transillumination defects and inflammation in the anterior chamber. But in our study doing upper lids, we didn't do internal shields. There was no adverse events. The 24 years of doing this, I've had no adverse events without internal shields. And now these wavelengths of light are being used to help patients with any kind of retina problem. In those patients that had IPL where they weren't covering their eyes, even though they had a inflammation in their anterior chamber and transillumination defects, they had no problems in their retina, and this is now following these patients for over 12 years. We did a study for a company using internal shields that we were not allowed to publish, showing that there were effects to the corneal endothelium and also to the confocals, which I mentioned before. So there's no reason to use internal corneal shields, and you're putting the patient at risk. So the protocol, and this is the FDA approved protocol in the study that I did for FDA approval with another system for specifically dry eye disease, is a 2-pass trachea to trachea protocol. A 2-pass, so for using this Lucent Darwin system, for the upper lid it's a 2-pass system with the upper lid, usually about 10 joules, and then a 2-pass system trachea to trachea. External shields covering the eyelashes, no internal shields. Treatments are done 2 to 4 weeks apart. I wouldn't wait any longer than that. Each IPL system is different, so you can't extrapolate the settings for one IPL system to another. So I have specific parameters and protocols for this Darwin system. And variations, the one thing I want to say is variations in the Toyos protocol have not been used, or excuse me, have not been published. In our other studies where people have deviated from the Toyos protocol with their own protocol, we found that there was less efficacy and failures. So I think if other protocols want to be used, they need to be studied and they need to be published. The protocol that I developed, I did over several years of trying different energy levels, parameters, and protocols. So stick to the protocol if you want the highest efficacy. And here it is. So doing the upper lids first, and here's the parameters that I use for the upper lids. Triple pulse, 6 milliseconds on, 100 milliseconds thermal relaxation time at a fluence of 10, and I do that for every skin type. And then for the trachea to trachea, you can change the fluence anywhere from 10 to 14. Change the thermal relaxation time anywhere from 80 to 100, but you stick to the 6 milliseconds of fluence. And here is video, upper lid treatment, and also the tracheus to tracheus treatment. I'm always asked, why do we do tracheus to tracheus? I did studies looking at just treating the lids versus treating ear to ear and treating whole face. Tracheus to tracheus was the same as whole face, with the least amount of efficacy being the lids. We now know that these telangiectasias, which is one of the mechanisms of action, are coming from the ear towards the lid and coming from the nose towards the lid. So when you're doing tracheus to tracheus, you're actually decreasing those telangiectasias that are feeding the lid margin. You're also decreasing the amount of inflammatory mediators around the skin around the lids, making it work better. Now, if patients want full face, I will add full face, and what I usually do is, since that's thicker skin, I'll do my dry eye treatment first, and then I will do the rest of the face, the jawline and the forehead. I will not do upper lid. The reason being is that men and women have hair follicles in the upper lid. If you treat the upper lid, you could get some adverse events because the hair follicles are absorbing energy. So this is the Toyos Darwin protocol, which Oculus can provide to you when you get the system. And then when I do the full face, I usually just add 2 joules to the rest of the face. So if you do 10 joules tracheus to tracheus, then you'll do 12 joules for the rest of the face. If you do 12 joules tracheus to tracheus, then you'll do 14 joules for the rest of the face. And then when we do the dry treatment and then add face, we usually charge the patient a little bit extra to do a full face IPL. If I have patients that are coming in for cataract surgery or refractive surgery, I will do 2, if they have some dry eye disease, I will do 2 IPLs with expression, and then a week later do the surgery. And then a month after their surgery, I will do another IPL treatment. I'm no longer, I've been a LASIK surgeon for since residency 26 years ago. I no longer do actually LASIK. I actually do SMILE. I find on Confocal that the Confocal is more disrupted with a LASIK procedure rather than a SMILE procedure. So I've converted to SMILE, small incision, refractive procedure, because I find it has less effect on dry eye and dry eye patients. And this is a SMILE procedure and a cataract procedure that you're seeing. Again, small incision, you're taking out the lenticule, less disruption of the corneal nerves. For chalazion, what I'll do is I'll use the small tip. That's if the patient does not want a full dry eye treatment. I'll use a small tip in the area where the chalazion is, 2 to 3 passes in that area with whichever jewels that you were going to normally use for that skin type. So a Fitzpatrick type 1, I'd probably use 12 jewels. A Fitzpatrick type 4, I'll use 10 jewels. 2 to 3 passes in that area. I'll try a gentle expression, start them on a steroid antibiotic 4 times a day, a drop, and then I'll bring them back in 2 to 4 days and repeat the procedure, and what you'll find within a week that the chalazion or hordeolum is gone. Now, if they have a long-standing scarred meibomian gland, and they keep getting recurrent chalazions, what's happening there is that scarred gland is pushing on the glands next to it, causing decreased flow. So even in a scarred chalazion that has a new hordeolum, you want to do this technique because you'll find it will help. You can't do anything about the scarred chalazion, but you can actually get the glands around that scarred chalazion working better and producing better meibum. So low-level light treatment. So this is my patented light treatment that patients use at home. Low-level light treatment is using LED instead of a xenon flash lamp. It's less energy, so whereas IPL is 10 to 16 joules, this is about 3 to 6 joules of energy. It's LED, so it's safe. LEDs are being used to treat age-related macular degeneration because it's helpful for the retina. So I'm not worried about these patients causing any harm to their eye. I tell them not to stare at these lights because it'll bleach out their photoreceptors, but this is something that they use at home where they take the cue, put it on the lid margin for about 2 minutes on the lower lid margin, 30 seconds on the upper lid margin, and with 5 minutes of treatment twice a week, they can keep these meibomian glands working so that they need less maintenance treatments. So with any of these things, whether it's my supplements or with the Q, the home low-level light treatment, these are things that you can purchase from Toyos Clinic and you can sell to your patients. So all you have to do is contact Nikki in our office and she can get your clinic set up with that. There's a photobiomodulation conference that happens every year where they bring doctors from all over the world that have been using light treatments to treat various diseases. I was honored to actually present this year at the 2024 conference and presenting light treatments like IPL and low-level light treatment for dry eye disease. You can use IPL for other aesthetic treatments like photofacial to get rid of pigmented spots like melasma, to help your rosacea patients, and to help your teenagers with acne or anybody with acne. So the system is very adaptable to use in your aesthetics clinic. So I get this question all the time: how do all of these other aesthetics procedures fit into dry eye? And let's think about RF. So radio frequency is electromagnetic energy creating heat in the dermis so that you can stimulate fibroblasts to make elastin and collagen. What I tell people is what I found using all of these aesthetic treatments like CO2 laser, microneedling, all RF, all of these will help the skin, and if you help the skin, you can help meibomian gland dysfunction. But the number one treatment in the uh, aesthetics armamentarium for dry eye disease is intense pulse light, because you get photobiomodulation. Then below that is low-level light treatment. So I would say that would be your mid treatment in the aesthetics clinic that can help patients dry eye disease. And then you have all these other treatments are low level to treat dry eye disease. So RF is one of them. I would not combine RF and IPL at the same time, because as we talked about heat shock proteins, too much heat in the dermis will actually shock the cells into not working, and you can cause scarring. So the way we use RF in our practice is as a maintenance treatment. So after you go through the 4-treatment protocol with IPL, you could use low-level light treatment at home, and then you can come periodically for RF and expression. So it is going to generate heat in the dermis. It will open up the glands. It will melt the secretion, so you have an easier time to express. So here's like a typical patient. We'll do 4 treatments of IPL. We'll get their meibomian glands back to normal and secreting a normal secretion, and then they'll come in 3 months for an RF treatment for expression, and then 3 months after that come in for a maintenance IPL. So I would say about maybe 10% of our patients that we're treating for dry eye with IPL and low-level light treatment get an RF treatment. So IPL is the gold standard. Low-level light treatment is a good maintenance therapy to do at home, and RF and fractionate CO2 laser is something to help the skin and will help dry eye disease minimally. So the confocal, we have 2 confocals, one in Nashville and one in New York City, has shown us a lot, and why we need to be treating aggressively these patients with dry eye disease, because on the confocal we can see all the things that we don't see on our slit lamp. We can see inflammatory cells, we can see T cells, we can see nerve damage, we can see scarring, we can see inflammation. And so this is just showing how easy it is to do a confocal microscopy. This is, the cornea is the most highly innervated part of our body, so you could see any kind of disruption there can cause severe pain to the patient. This is a confocal video, so this is the kind of detail that you get by doing confocal on these patients, and this is why we know so much about the dry eye disease pathology and what happens over time. So let's look at a few confocals. So you have a patient who's had LASIK and they're complaining about pain. You look at the cornea looks completely clear, and you don't even see the flap edge. But then you do a confocal and there is the flap edge. It's caused a scar across the cornea that the corneal nerves have not been able to bridge. So this patient, we would do IPL to increase their normal tear production, and then either give them platelet-rich plasma that has nerve growth factor or purified nerve growth factor with Oxervate. Here's a patient that, again, patient with pain. You do the confocal and you see these thickened, inflamed nerves. Here, patient with missing nerves and then this hyperreflectivity, that is an area of extreme microscopic inflammation in the cornea. So this is what an inflamed tear does to the cornea. It destroys the corneal nerves and causes inflammation in the cornea. Here is a patient with extreme pain. Why is that? Because they have these abnormal nerve cells that are coalescing to cause neuromas throughout their cornea. They have abnormal, thin, supersensitive nerves. This is a patient pre-treatment where they have no nerves, inflammation throughout the cornea. We do IPL and gave them PRP, and you can see we've decreased the inflammation. They still have some inflammation, but they've regrown their nerves. And then this is great work out of Australia. Dr. Chinnery at the Lions Eye Institute showing how there's T cells in our cornea, and these T cells actually can move. So the cornea is kind of a living, breathing organism, and it has these T cells that inflammatory cells that can move. And this is groundbreaking work and showing us how much is going on in our cornea and why we should be treating these patients with dry eye disease aggressively. We can also use the confocal to look at the meibomian glands. So a lot of people believe that the meibomian glands are fibrosed. The confocal is showing us that very few patients have fibrosed meibomian glands. So there's no need for probing on 99.9% of these patients because they have an open gland. We have a teaching facility for doctors if you want to train on how to use the Darwin system. We have a Saturday clinic in New York City that has a Darwin system, and we also have a Darwin system in our Nashville office. You can set up to come spend the day with us as we're treating dry eye, and you can see exactly all the things that we do. We also have confocal in both the Nashville and the New York office. It's been great to have this opportunity to talk to you about IPL, dry eye disease treatment, aesthetics, and all of it. So I want to thank Oculus again for giving me this opportunity.
Well, Rolando, thank you so much for sharing your expertise tonight. And any other questions that we get, we will definitely answer via email. I'll share them with you. And I wish everyone a great evening tonight. Have a great night, everybody. Thank you.